And I want to take this opportunity to express my gratitude for including in this great group, amazing discussion, amazing data, and also congratulate you for always pushing the envelope of cutting edge laser vision correction and diagnostics. And my talk will be very pertinent to both of those principles. I'm going to share with you some of our data with Innovyze. Basically, it is ray tracing. And let me see, I want to advance my slide here. These are some of the equipment that is currently available. And we heard a great talk by Mark Lobanov, who works and has really excelled the concept of topography guided and wavefront guided. We heard also from Ed Manch, has been around for many years and is also a concept in evolution. And of course, we focused a lot on all these technologies being always scrutinized by a very careful assessment of the surface of the eye. Epithelial maps have really been a game changer in noticing fluctuation and refraction, the accountability of our devices that we use to measure the eye, and at the end of the day, our refractions as well. We've worked with topography guided for almost 20 years now, and it was first developed as a tool to fix sick eyes, to be able to enlarge small optical zones. And this is a little bit of museum material from the Academy of 2005 presentation at the ISRS then, showing how you can treat enlarged optical zones, treat irregular eyes, cornea scarring on the bottom from herpetic disease. These were eyes that if they were intolerant to contact lenses, in my training, we had to do a cornea transplant. And now you can use laser technology to improve them. And we've worked a lot in using this in conjunction with cross-linking in ulcer-keratoconic eyes. And we've heard a lot about topography guided. I'm going to just brush through it. We had found that by normalizing and reducing the higher aberrations and coma with topography guided on the cornea and using some of the topography measured cylinder, you can excel your data. And this is our publication from 2016. And also a recent study that we did comparing going 50% TMR. So adjusting your astigmatism by 50% between the difference of your refraction and your topography measured, and the axis difference by 50% is enough to improve your outcomes with laser vision correction. And I want to add here that these outcomes are great even with standard corrections. We see here the blue boxes, eyes that have gained 2 lines with just wavefront optimized ablation. And it's very impressive that the laser industry has reached this point. And I do consult for Alcon, but the biggest interest I have is in the outcomes of my patients, obviously. Now, 50% TMR we're seeing here is able to boost that number to almost 30%, just over 30% with 100% TMR. So we're kind of quantitating how much TMR is enough. But now we're going to a different ballgame. Otherwise, it's very difficult to explain. I'll try and do it as succinctly as I can. It's based on a new device that is available as a diagnostic device by Oculus. And it is basically a interferometer that also can provide pentacam measurements, Sine-Flug imaging tomography, as well as wavefront measurements using the Hartmann-Shack method. So 3 devices in one. And this device has been adopted by Alcon WaveLight to be able to gather these data and develop a new customized treatment. And I'll explain to you how. So in ray tracing, and some of this stuff is revolutionary for laser vision correction to begin with. We're going away from the gold strand eye model that all lasers use to deliver the laser treatment once we dial in the refraction or even customize refractions. And in ray tracing, the artificial intelligence software builds an avatar eye for each eye that's being evaluated by the actual length measurements provided by the sitemap, or this is what the WaveLight calls the Oculus device as a diagnostic device for the Innovyze treatments. So it builds an avatar eye, and then it uses the Seinflug imaging, so the pentacam, to ray trace 2,000 rays through the air, incidence on the tear film, through the front part of the cornea, back part of the cornea, into the aqueous, and onto the anterior surface of the lens. So this is the forward-going ray tracing of 2,000 rays in a theoretical model. And then it uses 2,000 theoretical rays traced from the retina, now utilizing the Wavefront maps, through the vitreous cavity, through the backside of the crystalline lens of the patient, through the lens of the patient, to the anterior surface of the lens. So we're having these two towards and from the eye, 2,000 rays being traced, as well as we'll see here in step 4, a very important step, measuring the tilt between the cornea and the lens. And I'll speak about this a little bit later when we treat eyes like keratoconic eyes. So through these data, we're having very accurate measurements of low order aberrations. The device is very precise. We use it as a backbone in really checking the status and the skills of not only myself, but our whole team here. It has very high reproducibility, but also the higher aberrations. And for us, from my personal experience, we have not worked with a device that has so consistent high order aberrations through different days of using it with patients. Now, these are the data that we published just a few months ago. We have been lucky to use this device from November 2019, when it did receive a CE mark, which means clinical ability within the countries of the European Union, including Greece. We've treated refractive errors that are in average for all the studies we performed previously, average about -5, astigmatism range from 0 to 4 diopters, so some eyes with significant astigmatism, and higher aberrations seen here. And this is an example case, very typical for the outcomes that we're having. Again, I want to underline here that in order to reach this point, to reach this result, we have to screen all eyes for naive epithelial surfaces and for consistent exams throughout, meaning our placido disc topography, although not used in this process, needs to be impeccable. Our epithelial maps need to be impeccable, so we get the green light and we base our treatments on this very sophisticated artificial intelligence platform. So proof in the pudding, measure these eyes with a device after treatment. So we're seeing if the device itself kick up low or high order aberrations. And sure enough, the device is flirting with 0. Very, very impressive. We've also worked with this in keratoconic eyes, and the very intricate thing with keratoconus, and this is where the tilt comes in place, is that ray tracing, if you're able to image keratoconic eyes, some keratoconic eyes are so regular that you cannot obtain Wavefront maps with them. But if we're talking stage 1 and 2, this software perceives keratoconus as a tilt of the cornea towards the whole eye optics. So it tends to treat more the superior part of the cornea instead of the bulging of the cornea that's typically infratemporal. And this is pivotal in treating these eyes with laser because it removes minuscule amounts of tissue from the actual cone. And this is probably the most prohibitive thing of performing laser in keratoconic eyes. You really don't want to thin those corneas further. And we have a paper in print for the Journal of Cornea showing the first cases, feasibility of using Innovise even in some irregular eyes such as keratoconus, and the ability to treat total eye aberrations, not just front and backside cornea aberrations, not just Wavefront aberrations, but total eye aberrations with this artificial intelligence. This is a specific case that has been reported, will be in print in the Journal of Cornea imminently. We can see before and after on the top right and far right top, the difference map showing the very effective normalization of these corneas, and a regular eye that cannot just be evaluated with visual acuity, it has to be evaluated also with quality of vision, et cetera, going into normalcy. This particular patient was an architect and really appreciated the improvement. So in summary, ray tracing is really a new concept. There are some limitations on its use. It needs to be used with very high reproducibility, needs to be used in pristine eyes as far as cornea imaging, epithelial maps, placido disc topography. In my opinion, principles that we should employ in any vision correction with laser. We are introducing this as a means to treat irregular eyes as well, as far as it can be measured by this technology. And we're waiting from our friends in the US and the multi-center study in the US, as well as an international ongoing multi-center study to, of course, validate these data with more cases and more investigators in play. Thank you very much for giving me the privilege. Really a pleasure to share with you these very exciting data from Athens.